Hello, I'm Liz Heileman from HIVandHepatitis.com, and we're here today at the Conference on Retroviruses and Opportunistic Infections with some experts on hepatitis C to talk about some of the recent developments in the field. We have Bart Reinders here from Erasmus Medical Center in Rotterdam, and then we have next to him David Thomas from Johns Hopkins University in Baltimore, and finally Kenneth Sherman from the University of Cincinnati. So, to start, now that we have very excellent treatments for hepatitis C, it looks like the field is moving more into the idea of talking about expanded access to those treatments, of course, and what sort of impacts we expect to see on the hepatitis C epidemic. Do you want to talk about that in general?
Yeah, sure. You're exactly right. The news a couple years ago was that we for the first time had safe and effective treatments for hepatitis C, and we would at this meeting and others celebrate the fact that you could give people pills and expect more than 90% of them to be cured. And as fantastic as that was, that just demonstrated that it was possible to cure people. And now the question is, are we taking those medications and are we able to distribute them into the populations that need them and have impact, if you will, at the population level? And so the attention today at the meeting, and I think in general, is how well are we doing on that? Are we getting these medications out into our countries, into populations that are at high risk, and are they starting to have impact? Are we lowering the disease burden? Are we lowering the numbers of new infections and that sort of thing? Those are the questions that we're now asking and where the focus is.
Okay, and Dr. Reinders, you actually presented some data today about exactly that issue among gay and bisexual men with HIV in the Netherlands. You want to give us a recap?
So now 15 months ago, the Dutch government decided to have these drugs available for everybody, so unrestricted availability of these new drugs. And within the HIV-positive MSM group, the uptake of these drugs was very, very rapid. These patients, of course, want to be treated as soon as possible because they don't want to infect their partners. And the HIV treating physician can prescribe these drugs without any restriction. So the uptake was very rapid. 75% of the patients with hepatitis C were cured only 14 months after the drugs became available. And we modeled previously that if we would treat everybody, that the number of new infections would go down because these cured patients cannot infect partners. And that's what we actually measured now with real data. In 2014, we measured the number of new acute infections in 17 hospitals, and we found approximately 100. So 1.1% of these patients get a new infection every year. And after the rollout of these drugs, so in 2016, we had 50% less infections. And actually that came at a time when the number of syphilis infections in these patients increased substantially. So this, for me, proves that the treatment of all these patients also prevents new infections. And that's also important if you look at the costs of these drugs, but these are very expensive drugs. But if you prevent new infections, eventually it will save you money.
Great. You want to add anything on that topic?
Well, the study that was just described is really very important. We've had models for a number of years that have suggested that that should happen. But this is the first demonstration, real-world demonstration, that indeed that can happen. And I think that provides some powerful ammunition for us to go to policymakers in the United States and begin to remove some of the restrictions that we have. We're currently in many states still facing restrictions on the stage of disease that we could treat, with only advanced stages being treatable, treating people who might be using or abusing drugs and alcohol as a restriction rather than a medical decision in individual patients. And in some areas, even which practitioners are allowed to prescribe these medications with limitations that include infectious disease specialists and gastroenterologists and hepatologists, but excluding many others from even being able to prescribe these meds.
Okay, and you want to talk a little bit about the contrast between our situation in the United States and some of the countries in Europe where the treatment is more widely available?
I mean, I only have the U.S. perspective, but just as Dr. Sherman was saying, that contrast is important. And if you're not familiar with this field, you might even be shocked to know that persons in the United States aren't allowed to get these medications in some instances unless they have enough disease. It's kind of like in the day with HIV when we weren't allowed to give someone antiretrovirals until their CD4 got low enough. And then it was so obvious that that was wrong and bad medical practice that we made it so that everyone could get access to treatment. And with hepatitis C, it's even more clear. With HIV, there was always this sort of overriding question of maybe actually long-term use of the medication would be unhelpful. And so there was this sort of risk-benefit trade-off. And so there were even cost notwithstanding some reasons for withholding treatment. But with hepatitis C, it's all about money. It's the only reason to not treat somebody is to save the money. And so that makes it really challenging in a resource, in a country with lots of resources, to not be able to do what's being done in Europe and to be what's being done in fairly widespread in different parts of the world. So I think that contrast is really important and shouldn't be sort of underappreciated. And the very the very population that we found out today could be treated, 75% get up onto treatment and have a reduction in their incidence. Our high-risk groups in the United States are not allowed to get treatment in some states. They're denied treatment because of the concerns that they might be reinfected or whatever reason. So the contrast couldn't be more dramatic.
So pushing things way to the front, some of these results you're getting kind of presume that people will be treated during acute infection, which is in the first stage. Traditionally with interferon, they would wait to see if people cleared it naturally because the drugs were so difficult to take. But now we're hearing more about treating people as soon as they are found to have hepatitis C, in which case they wouldn't have to wait.
Yeah. Well, there are, I think, several reasons why treatment during the acute phase would have advantages, but there is the problem that none of these drugs are approved for acute hepatitis C, so that's an issue. And these studies have to be done to get it on the label, I think. But most of the studies show that during acute phase of the disease, you can treat shorter. And the results are not always consistent, but we are doing a study now, I think enrolled 60 patients, where we treat for 8 weeks instead of 12. So that makes it still expensive, but less expensive. And the chances of clearing spontaneously, if you're HIV positive, are like 15%. So if you can treat shorter, then it will be less expensive to treat during the acute phase right away. And of course you will, because these patients had a very recent hepatitis C infection, they are very active sexually. So I think if you wait for 6 to 12 months, they will infect other people. You can try to counsel, but that's not always possible.
And I assume the same would be true for people who inject drugs being treated early.
So early in infection, viral loads go very high before they fall back to a stable set point in most patients. And that initial period may represent a hyperinfectious period of risk for transmission to others. It's not how we've approached treatment in most places in the world, but thinking about it that way and dealing with the reservoir that contains the highest risk for transmission would be a very desirable approach to try and dramatically cut down on new infections. New infections are occurring in pockets in the U.S. at extremely high rates associated with an emergent heroin epidemic in some places. And it's just amazing the number of new cases that we're seeing in our part of the country, in Ohio, and surrounding areas, and it's concerning because if we don't address it, then the estimates made by the CDC, as described by John Ward and others, may not be achievable because the number of new cases that emerge may overcome our ability to treat a certain number in a certain fixed time period and prevent us from actually...
And his prediction was that hepatitis C might be eliminated as a public health threat by 2030. So you're
Right.
saying that might not happen if we don't.
Well, I'm concerned that many of those models that are used to predict that have not taken into account the growth of new cases and the difficulty of treating those new patients. And they think that there's around 30,000, 31,000 new acute cases of Hep C in the U.S. in 2015. It looks like that is rapidly increasing for those with their feet on the ground seeing patients, and we're going to have to address that.
And finally, I'd like to sort of ask each of you in turn to say, you know, what else from this meeting or in general is the big exciting news or the unsolved problems in the hepatitis C field at this point? You want to start, Dr. Reinders?
In the hepatitis C field, you mean, or
Liver
general,
disease field.
The liver disease field. Well, I think there were some data about new drugs coming and the interactions with the HIV medication. That was something that I looked at in particular because some of the newest hepatitis C treatments will be even easier to use. All genotypes, maybe 8 weeks for chronic for almost all, which would make it easier to implement. That's something from the hepatitis C field what I saw. And what worried me, unfortunately, was data from the German researchers showing that in HIV-positive MSM that the reinfection rate was 11% in 1 year after cure. So that's but that's maybe also because the treatment uptake in Germany is not like it has been in the Netherlands. But yeah, these reinfections are a problem, and treatment for all is very important. But there also have to be other interventions specifically to avoid new reinfections.
Dr. Thomas?
Yeah, so we've already talked a bit about this, but there's goals set that by 2030 there'll be a 90% reduction in incidence and a 2/3 reduction in the number of deaths due to hepatitis B and C around the world. And so that's a line in the sand, and every country is going to be measured on how well they achieve those goals. And some are rapidly moving in the right direction, and in the United States, I think that's one of the things to keep an eye on. How are we doing towards that? Dr. Sherman just said that we're not moving in the right direction with a 90% reduction of incidence. We've just experienced a multifold increase in incidence over the last 3 years. So we're going in the wrong direction on that part of the WHO goals. I think one of the things I'll point out that probably otherwise wouldn't come up is that it would really be helpful if we had a vaccination to protect against these new infections. And it's a goal which I believe is achievable. It's one that's been way under-resourced. And if we put a tenth of the money that we put into HIV vaccine development into Hep C, I think we'd be pretty close, actually, right now. It's a more achievable goal than, I believe, than with HIV, or at least one that would be one that we could see progress on.
That's maybe something we'll see at future meetings, hopefully. Dr. Sherman?
Well, as we begin to have the tools and the ability to control hepatitis C, we're seeing the emergence of a new epidemic of liver disease, and it's worldwide, but it's particularly in the United States associated with an obesity epidemic. Combined with aging of the population, and that includes our HIV-infected patients as well. Patients are developing fatty liver, Some patients with fatty liver develop an inflammatory process called NASH. In many centers that do transplants, NASH has now emerged up to second as the leading cause or among the leading causes of need for liver transplantation. Projections and estimates suggest that this is going to get much worse, and that as we begin to see a decline in the cases of Hep C associated liver disease that need transplant, we're going to see a concomitant increase in the number of NASH associated cases. NASH is difficult to diagnose. Today, definitive diagnosis requires a liver biopsy, something we've moved away from over the last few years, but now we're back to, do we need to do that? We're in the infancy of developing biomarkers and other non-invasive imaging tools to make the diagnosis. And there are a large number of drugs that are just beginning to be seen in early stages in the pipeline, but we're a long way away from actually having treatments for this disease process. And I think that over the next few years at this meeting, we are going to hear a lot more about the role of NASH in our patients.
Okay, well, thank you all for sharing your thoughts with us. Signing off from the Conference on Retroviruses and Opportunistic Infections in Seattle. Thank you.